Welcome to another session of Voices in Health. I'm your host, Dr. Barbara Kostick. Our focus today is on decisions in cardiac care. According to the National Institutes of Health, coronary artery disease is the most common type of heart disease and the leading cause of death in the United States for both men and women. The two most common treatment options for coronary artery disease are cardiac catheterization, where a closed artery in the heart is held open with a device called a stent, and open heart surgery, where a path is created to go around the blocked artery, allowing the blood to flow freely again. Every case is unique, and the choice of treatment is not always an easy one to make. So it's very important for a patient to have the necessary information to make an informed decision. Today, we'll be talking to two Washington Hospital heart specialists to discuss these treatment options and help you better understand which is most appropriate for a given situation. Our first guest is a cardiologist and the medical director of the Cardiac Catheter Lab and Peripheral Vascular Services at Washington Hospital, Dr. Jain. Welcome, Dr. Jain.
Thank you, Barbara.
First of all, let's talk about what is coronary artery disease.
Coronary artery disease is when there are disease in the arteries that supply the blood to the heart. There are three major arteries, and these are the ones that cause heart attacks if they are blocked.
And they're usually blocked by certain things, aren't they?
They are blocked generally by a plaque, which is a buildup of cholesterol material, and is called as atherosclerosis.
And how do you diagnose coronary artery disease?
Coronary artery disease is diagnosed basically by eliciting a history from a patient. If the patients have complaints of chest pain, shortness of breath, dizziness, mainly with exertion, that is typical of coronary artery disease and is called as angina. Now, if they have that symptoms, then you do further workup.
But they don't always have to have classic angina symptoms, do they?
No, they don't, and most of them don't. Most of them may have shortness of breath, waking up at night feeling short of breath, having dizzy spells, passing out, even palpitations. So they can be vague symptoms. And even the chest pain can be at other areas in the heart or in the body rather than being in the chest. So it is taking the cue from the history and then diagnosing it further.
So you've gotten a history that makes you suspicious for coronary artery disease. What's the next thing you do?
Then you want to examine the patient, and the next step, which really helps you, is doing an electrocardiogram, which is called as EKG. And that will tell you mostly about the past or the present, but doesn't tell you whether somebody's at a risk of having a heart attack or not. But it is helpful because that leads you to the next step, which is doing a stress test, which is how really you make a good diagnosis, or a diagnosis that will lead to telling you 95% of the time whether the patient has blockages in the heart arteries or not.
And then what do you do if the stress test is positive?
If the stress test is positive and a patient is a candidate for some kind of an intervention, which may be even aggressive medical treatment versus angioplasty, opening up the arteries with balloons or stents, or bypass surgery, then you go to the next step, doing an angiogram. On the other hand, if a patient is not a candidate for any of these interventions, then there's really no need further to diagnose the problem, because you are going to treat them medically, and medical treatment is pretty standard.
What would make a patient not be eligible for the cardiac catheterization?
If they have terminal disease, if their life expectancy is less than 2 to 3 years, if they have a severe stroke or severe lung problems, severe kidney problems, not on dialysis yet, these are the things. They're not absolute contraindication, but they are a patient population where you want to avoid doing an angiogram.
So you have to evaluate a patient even if they have a positive stress test to see if you need to do further studies or not.
Yes.
And then what would you do next if they are a candidate?
If they are a candidate for an angiogram, you do an angiogram, which is a test which is done generally in a hospital setting, and it is invasive. You have to enter the one of the arteries in the body, which may be through the groin or maybe through the arm, and put a catheter right into the heart artery and inject some dye. And that outlines the arteries, shows you the pictures of where the blockages are, and based on that, you make further decisions.
And when do you decide to put in a stent?
If there are blockages in the heart arteries, then you have three options. One is medical treatment, second is opening it up with a stent, and third is bypass. It is not a cookie cutter here that this lesion is for stent, this lesion is for bypass, this lesion is for... It depends on the patient, whole picture, the presentation, the examination, the associated comorbid conditions, and then where the blockages are.
Well, so what patient would benefit by a stent?
Stent is generally indicated for nice discrete lesions which you can open up with a balloon and a stent and you get a nice open artery. On the other hand, if it's a complex lesion, then it becomes very difficult to stent at times, and that is when you ask your surgical colleagues to help you out. Now, on the other hand, if it's a complex lesion and patient has bad surgical conditions like bad lung problems, has had a stroke, has other issues which surgery is not a good thing, then you can do a stent in that situation.
Okay, so you've decided that probably a stent is needed. Are there choices of what kind of stents to use?
Yes, and we've been lucky over the last 20 years, the stent technology has evolved tremendously. We used to have rigid pipes to put in the arteries, and they used to be difficult. We used to have complications, and not every patient could get it. Nowadays, we have stents which are very flexible, and we can go pretty much anywhere in the arteries to put them in. And also, we have now the drug-eluting stents. That means these stents are coated with drugs, and these drugs prevent from blockages coming back. There are pros and cons for everything that